Morning, everyone. I will be sharing my screen.
Yeah. Could you please share your screen, ma'am?
Yes. Are you able to see my slides?
No, ma'am. Not yet.
Okay.
Yes.
Yes? Okay. Okay. Is it visible?
Yes, ma'am.
Yeah.
Please start.
Good morning, everyone. Thank you for giving me this opportunity. So I will be presenting a case series of immunoglobulin G4 related ophthalmic inflammation and emerging disease. I have no proprietary interest. I will be starting with a short introduction. So IgG4 disease is an immune-mediated condition characterized by mass-forming lesion, lymphoplasmacytic infiltration, and raised serum IgG4 levels in 60 to 70% of the cases. It was first recognized as a systemic condition in 2003. It can involve several organs, the most important being pancreas, orbit, salivary glands, and orbit is the most common extrapancreatic site. In the orbit, lacrimal gland is the most frequently involved sites, and other being extraocular muscles, orbital soft tissues, and the orbital nerves. So the purpose of my study is to present a spectrum of clinico-radiological manifestations of IgG4-related disease with epidemiology and histopathology data, to evaluate the clinical outcomes of disease with targeted therapies like rituximab, and to monitor the response of glucocorticoid therapy in relation to serum IgG4 levels. So we did a prospective interventional case series in 30 patients between 2014 and 2019. We recorded the age, sex, and presenting complaints for the patient, recorded CRP, ESR, and serum IgG4 levels. All the patients underwent orbital imaging. As we can see, NCCT orbit showing bilateral lacrimal enlargement on the left side. On the right, we see MRI orbit showing comparatively enlarged infraorbital nerve on the right side. All patients underwent incision biopsy, and typical histopathology findings were follicle with germinal center, CD138 positive plasma cells, and IgG4 positive plasma cells. We followed the criteria given by Goto et al. There are three criteria. Firstly, the imaging study showing enlargement of lacrimal gland or trigeminal nerve, serum IgG4 levels beyond 135 milligram per deciliter, and the histopathology evidence of marked lymphocyte and plasmacytic infiltration, fibrosis, germinal center, and infiltration of IgG4 cells, number being more than 50 per high power field. So we diagnosed the cases as definite IgG4 when all the three criteria were fulfilled, a probable disease when we had imaging evidence and histopathological examination showing all the criteria, and a possible disease when we had imaging evidence along with raised serum IgG4 levels. All the patients were started on oral steroids and azathioprine. One patient had to be given IV methylprednisolone due to compressive optic neuropathy. 8 patients had to be given rituximab. So this is one of the example. 46-year-old male came with left ocular motility disorder to us. He had proptosis, hypoglobus, severe restriction in the left eye with congestion over the medial rectus muscle. CT scan showed enlargement of the muscles, biopsy showed fibrosis, lymphocytes, and positive IgG4 cells. Serum IgG4 levels raised, diagnosed at definite IgG4 disease, started with the treatment. After 4 months, he had good motility, reduced proptosis, and congestion. Second case, bilateral upper lid swelling. Response to steroids was good, was diagnosed as idiopathic inflammatory disease. As soon as the steroids were withdrawn, relapses and recurrences started. CT showed bilateral lacrimal gland swelling. Incision biopsy showed typical histopathology features, raised serum IgG4 levels, again diagnosed as definite IgG4 disease. Third case, left eye proptosis with upper lid swelling, again diagnosed as definite IgG4 disease. So we had 30 cases between 2014 and 2019, average age being 40 years. Clinically, 53% of the patient had dacroadenitis, and out of them, 10 patients were bilateral cases. 10 out of 30 cases presented to us with proptosis because of the various soft tissue involvement or the muscle involvement, and rest of the cases presented both with proptosis and lid swelling. 83% of the patients had isolated ophthalmic disease, and 16% had systemic involvement. Definite disease patients were 16 out of 30, maximum number. 8 patients were possible IgG4 and 6 were probable IgG4. And 73% had good outcome with the regular treatment, and 8 had to be given rituximab. So the diagnosis of IgG4 related disease is critical as it responds very well to targeted therapies like rituximab. There is significant reduction in serum IgG4 levels with clinical improvement in response to glucocorticoid therapy, and serum IgG4 levels, wherever elevated, can help in monitoring the disease activity after initiating the treatment. Coming to the discussion, my study basically depicts the spectrum of manifestations, and the average age, however, was slightly lower as compared to other studies. Clinical presentation-wise, bilateral cases in our study was 46%, which is slightly lower as compared to other studies, and dacroadenitis was seen in 53%, again slightly lower as compared to other studies. We had isolated ophthalmic disease in 83% of the cases, and systemic involvement only in 16%. This is different from other studies, where extra ophthalmic manifestation was seen in 78% of the cases. Earlier, we used the criteria of Omehara et al., where clinical examination was given importance, and histopathologically, more than 10 IgG4 cells were enough to make the diagnosis. But we shifted to more specific criteria given by Goto et al., where imaging studies were given importance. Pathologically, IgG4 cells had to be more than 50 to make the diagnosis. Also, the definite disease was 53%, but possible efficacy was only 26%. That means 26% lacked the histopathology findings, and 20% had serum IgG4 levels as normal. So these criteria, they reflect the reality of the clinical care in IgG4 disease, and clinicians must consider—
Sorry to interrupt, ma'am. You have to conclude as your time is up.
Just 5 seconds. Clinicians must consider a combination of factors before classifying the patients as IgG4 disease. Standard treatment remains oral steroids and immunosuppressants. However, we can give rituximab in resistant cases. It has got good results. Long-term follow-up is a must because there are chances of lymphoma. However, we plan to conduct further studies with the new criteria given by ACR and to look into the further role of rituximab in the disease. Thank you.
Judges, any comments?
No, it's a good paper. Congratulations, Amrita. I think you have won the award also.
Thank you very much. Thanks very much, ma'am.
Please work on it. Please work on it. Yeah.
Definitely.
Because trigeminal involvement, you said, but I think we didn't see any clinical slides of that with corneal involvement.
Yeah.
That's a very important point. Sometimes they need evisceration. So please work on this further. It's a very good series which you have. Congratulations.
Thank you very much, ma'am. Thank you. Thanks.
Thank you.